Okay. Okay, so good afternoon and good morning, everybody, depending on which part of the world you are now. Welcome to the Distinguished Talk webinars. Today we have a guest from Boston University, Professor Darren Roblyer. He received his Bachelor of Science degree in Biomedical Engineering from Johns Hopkins University, and then his PhD in Bioengineering at Rice University in 2009. Then he did his postdoc at Beckham Laser Institute at the University of California. Now he is developing label-free optical techniques to interrogate tissue physiology, metabolism, and structure over broad spatial scales. And today, Professor Roblyer is with us to have this very interesting talk, webinar, that is titled New Advances in Diffuse Optical Spectroscopy and Imaging for Clinical Treatment Monitoring. Please, the screen is yours.
Thank you very much, Valentina. And thanks everyone for attending today. I'm excited to talk to you. I'm just going to share my screen here. And can I get a confirmation that you can see my presentation?
Yes, it's okay.
Okay, perfect. And you can hear me all right?
Yes.
Excellent. Okay, yes. So thank you again for attending. Good afternoon. It's a snowy morning here in Boston, but feeling nice and warm inside. So yes, I'm at Boston University. My lab is called the Biomedical Optical Technologies Lab. We also call it the BOT Lab. And I'm in the Department of Biomedical Engineering. And my lab works on a number of different optical technologies, but we really focus on this one called diffuse optics. And there's diffuse optical spectroscopy as well as imaging. And we're a translational research lab, meaning that we really like to image humans. So I want to kick off today by first explaining to you what I mean by diffuse optics, because it's probably more familiar to you than you might first realize. So here we go. So I'll start by showing you this image. So this is an image of a collimated light beam going into a scattering medium. So this could be water with scattering particles like titanium dioxide, but some particles that scatter light, so they have a different index of refraction. And the reason I'm showing you this is because it gives you a sense of how light propagates through tissue, which is also a scattering media. And the scale of this doesn't really matter, but if we link it to tissue, the course of the traverse of this light path is just over a few millimeters. And over to the left side, where the light is coming into this media, we have what we call the ballistic regime. So this means that most of the photons have traveled and not yet undergone scattering or significant scattering events. And as we move to the right, there's increased photon scattering until the point where those photons are propagating almost isometrically. They're undergoing random walks and they're propagating in every direction. So they've lost that initial directional flux. And we can model how light moves on this side of the plot using versions of the diffusion equation, and that's why we call it diffuse optics. But so much of imaging that we're used to is microscopy and is focused on this side of the plot. So for example, here is showing an example of a confocal microscope image of a biological sample. And you can see it's high resolution. And one of the reasons that it's high resolution is that this modality rejects multiply scattered light, which would degrade resolution. And you can see that in the comparison with the wide field compared to the confocal, which has a pinhole that rejects multiple scattered light. And this is true for reflectance or fluorescence confocal. So the advantage here is that we have very high spatial resolution, can be in the order of microns or even better. But the limitation is depth of penetration in biological samples. We're limited to tens or hundreds of microns, which is very useful for looking at cells, but really we can't go much deeper than that. Multiphoton imaging is really at the leading edge, and there you can image in the brain, in the mouse brain, about 1 millimeter, and that's it. If we go over to the right side of the image again, where we're talking about diffuse optics, you can see that photons can actually travel very deep in tissue, so millimeters or centimeters. And you're familiar with this if you've ever put a flashlight under your hand or your fingers. You can see the diffusely propagating photons coming through, and you can see sort of this broad glow. And so that tells us, you can't see the structure of your hand like an X-ray. You can't see the bones or the blood vessels. you could just see this glow of light, and that's because of all this scattering. But some major advantages of working in this regime of photon propagation, as I mentioned, the penetration depth, that allows us to get past the skin to deeper muscle, to deeper structures like muscle. We can measure the metabolism of muscle, or tumors that are underneath the tissue surface, or even the brain. So the most superficial parts of the brain, we can measure with near infrared light that travels through the skull, and we can measure cerebral activation. And so all this is very useful for measuring physiology. In fact, you're probably used to a few different diffuse optical technologies. If you've ever had a pulse oximeter, take a measurement in the doctor's office or at the hospital, that's the clip that goes on your finger and it measures your arterial oxygen saturation. That uses diffusely propagating light. It sends near infrared light, transmits it through your finger to measure the change in optical absorption due to the expansion and contraction of your arterioles with each beat of the heart. Also, if you have a Fitbit or an Apple Watch, like I do, it probably has an optical measurement system that uses either green or red light and a photodiode. Again, this is for measuring your heart rate and then increasingly for oxygen saturation. So that's another example of diffuse optics. But I want to show you a few more examples of diffuse optics and a few different subgenres in diffuse optics in the talk today. So my talk, one more slide here just to center diffuse optics in the context of other imaging modalities. So this is a plot of spatial resolution versus penetration depth. So multiphoton and confocal microscopy are down here in the left-hand corner, whereas very clinical imaging modalities like MRI, CT, and PET are way up here. So lower spatial resolution, but you can image the whole body. And in between, there's optical coherence tomography, and here's diffuse optical imaging and spectroscopy. So it really bridges these spatial scales of these different imaging modalities. And just to know, unlike MRI, we can't see through the entirety of the body with diffuse optics. We can see relatively superficial tissues up to a few centimeters at the most. And it depends on the optical properties of the tissue. So muscle is very absorbing. We can't see quite as deep as we can, say, in breast tissue, which has largely composed of adipose tissue, which is transparent to light in a way that muscle isn't. So my talk today is in two chapters. The first chapter is on diffuse optical imaging in breast cancer. And I'm going to tell you a little bit about the specific version of diffuse optics we're using for breast cancer imaging. It's called the frequency domain diffuse optics. And the second chapter switches gears. And I'm going to talk a little bit about diffuse optical wearables for remote patient monitoring during the changing healthcare landscape during COVID-19 and then beyond. And I'd just like to say, I'm happy to take any questions during the talk. So please interrupt me. I can't really see the chat while I'm giving the talk, but I can hear you. So feel free to just audibly ask a question and interrupt me if you have one. I'd be happy to field questions. So let's get started on this first chapter, diffuse optical imaging in breast cancer. So I'll start this chapter by first telling you what the clinical problem is that we're trying to tackle. So in breast cancer, much like many other cancers, we unfortunately have what you might call suboptimal treatments for many types of cancers, including what we call locally advanced breast cancer. What's locally advanced breast cancer? Here's an example of a locally advanced breast tumor. This is an MRI image, and you can see the tumor against the chest wall in the breast. So it's locally advanced because it's grown quite large in the breast, but it hasn't metastasized to other parts of the body yet. That's the local part. And it's common for patients who are diagnosed with a cancer like this to get chemotherapy, some kind of systemic therapy that attempts to shrink this tumor prior to surgery. And this particular example, this patient number 1, this worked marvelously. So you can see that this tumor is gone after several months of chemotherapy. And she's considered a complete responder and is representative of about 20% of patients that are treated in this manner. But compare this to patient number 2. She started with a large tumor in the breast, got the same type of chemotherapy for the same duration, and that tumor is still there after months of treatment. So she's a non-responder, and she's representative of another 30% of patients treated like this. And the remaining 50% are somewhere in between. Their tumor shrank but didn't completely go away. So despite all the advances in genetic matching and molecular markers and even new therapies like targeted therapies and immunotherapies, this remains a big problem. There's just a huge variety of responses. And we really don't want to treat patients like patient number 2 for months with treatments that are ineffective. So this is the clinical problem. And then the clinical unmet need is we need technologies that can help us monitor these patients in real time to determine who's responding and who isn't. And we don't have that technology at the moment. So this part of the talk is making the case that diffuse optics may be one way that we can monitor these patients in real time. And why would we want to do this? If we could identify who's responding and who's not early during treatment, that gives us a lot of opportunities in terms of clinical care. So the standard dogma, the standard of care for cancer and many other diseases is to give a one-size-fits-all therapy. We match a therapy as best we can to a patient, but then we give a standard length of treatment, standard dosing that's generally determined by the size of the patient and generally limited by toxicities. But the newer idea that falls into this category of what you might call personalized medicine is adaptive therapy, where you start with your best first guess for a therapy. And this could be a regimen, a combination of drugs. You need some technology to determine, is this patient responding or not to this particular regimen? If yes, continue. If no, switch to a different therapy. So obviously this is much more personalized. You can change the treatment to match the patient. And you can also change things like not only the drugs, but the dose and the treatment schedule. So this feedback loop, right, which is quite obvious to us who've studied engineering and control systems, as well as the physicists, would be a revolution in clinical medicine. This is not how most patients are treated currently. And so there's a few difficulties here. Open questions include, again, what technology to determine whether a patient's responsive? How and when do we measure? Do we measure continuously? Which treatment do we start with? Which do we switch to? And interestingly, there's an open question of, will this increase or decrease costs, right? If you're continuously monitoring and changing treatments, that's a lot of time for both the patient, but also the healthcare system to be responding to the needs of this subject. So all these things have to align in order for you to change clinical cancer care. But it starts with what's the right technology. And you might ask, well, we have lots of standard of care imaging technologies. Why can't we use one of them? And that's a good question. I mean, you can think about things like mammography or MRI, ultrasound, or PET, which you see here on the left. But there's some limitations to these imaging modalities. Some of them are very obvious. You see in this PET image, this is a huge device. It costs thousands of dollars to scan each patient, at least in the United States. And so if we need to measure patients frequently, often during treatment, this just isn't going to work. It takes too long and the healthcare system won't support it. And more than that, the literature, at least so far, is not particularly positive about the idea of using these types of modalities to track treatment response. It's mixed, but especially anatomic modalities. So things that are looking at the size of the tumor, like ultrasound or mammography or MRI, they tend to correlate poorly with whether a patient responds or not. And we think that's because the anatomic tumor size is a lagging indicator of response. And really what you need to do is measure the metabolism of the tumor to see early responses of whether this tumor is responding to treatment or not. And that's where diffuse optics really has a few advantages here. So it's label-free, so no contrast agent. It's safe and non-ionizing, so we don't have the safety concerns of, say, mammography or CT. We can get functional information. We can measure hemoglobin concentrations and molecular information, water and lipids. We can even get some structural information from optical scattering. So this could be related to the environment, local microenvironment, and the microarchitectural attributes of a specific tissue. Devices are portable and inexpensive. And here's a little preview of what our diffuse optical spectroscopy. This is one of the acronyms we use to talk about a specific diffuse optical technique when we're measuring multiple wavelengths. And I'll use the acronym DOS or DOSE during this part of the talk. But this is the handheld probe that we scan across the surface of the tissue. And we can measure at different measurement locations and build up a topographic, or in some cases, tomographic map of the metabolism of the tissue below the surface. And here you can see an area of enhancement where a tumor is, as well as where the areola is. And areola often has enhanced metabolism and is just a different tissue compared to the rest of the breast. But we know that it's that way, so it's not an issue unless the tumor is very close to the areola. So near-infrared light, which are the wavelengths of light we use to measure the breast, can really reveal a lot about breast anatomy and structure and function. So just a few words about breast anatomy. The breast is largely composed of adipose tissue, which you can see here, glandular tissue and connective tissue. Most tumors originate in the ducts. You can see the ducts here, as well as the lobules to a lesser degree. And as tumors grow, they also generate their own blood supply through the process of angiogenesis. But I want to emphasize, again, compared to a tissue region like a muscle, the amount of hemoglobin, the number of blood vessels in the breast, is relatively low. This is advantageous to us because it allows us to image deeply. And so what we're looking at here at the bottom right are the unique absorption spectra of what we call the chromophores, or things that absorb light in the near-infrared range. So looking at 650 to 1,000 nanometers, we're looking at the relative absorption over wavelength of oxyhemoglobin, deoxyhemoglobin, lipids, and water. And these four chromophores occupy over 90% in most tissues of what absorbs light in this wavelength region. So this is what we really pay attention to. And lucky for us that each of these species has very unique spectral signatures. So if we take measurements at multiple wavelengths, we can determine the relative composition of these four chromophores, which is what we do when we monitor breast tumors during treatment. So DOSE, remember diffuse optical spectroscopy, one of the reasons it's useful is that it measures both the optical absorption and scattering of light. So when light comes into tissue, it can undergo many physical interactions, but absorption and scattering are amongst the most important. So absorption, meaning that you absorb the energy of the photon into some other molecule, hemoglobin, water, and lipids being the examples I gave you in the last slide. And then, of course, there's scattering, which I talked about in the very first slide. And if we want to know, say, how much hemoglobin is in a tissue, we need to somehow separate the effects of optical absorption and scattering. And we quantify absorption and scattering using the absorption coefficient, and in bulk tissue like this, typically the reduced scattering coefficient. And each of these are in units of inverse distance. So for the example of mu A, this is very simple. All it means is if you have an absorption coefficient of 1, it means that on average, a photon has to travel a path length of 1 millimeter before it undergoes an absorption event. So higher mu A, higher mu S, stronger absorption and scattering. The things that absorb light in tissue, again, hemoglobin, water, and lipids. And then in the skin, melanin is very important, and then collagen is important at some wavelengths. The things that scatter light are, just like in any other media, refractive index changes. But in tissue, this could be the difference in refractive index in the cell membrane, the different organelles, the nucleus, as well as the collagen outside the cell and the extracellular environment. And scattering is going to be changed by cellular density, the morphology, the shape of the cells, even things like osmolarity or edema. The amount of extracellular and intracellular fluid can all change, reduce scattering. Red blood cells themselves are quite scattering, so an increased density of red blood cells can also change scattering. So I'm going to show you this slide, which is a comparison of different types of diffuse optical techniques, and they're different from each other in their ability to fully separate absorption from scattering. So starting here on the left, continuous wave diffuse optics. This is, this idea is simple. You have a wavelength of light that has some intensity. Tissue decays that intensity and you measure how much it attenuates. And this attenuation is going to be due to a combination of both absorption and scattering. So this is how a pulse oximeter works. This is how, if you had an LED or a laser and let the light on at the same intensity and just measure the attenuation, you could determine the change in absorption over time if you assume some scattering and assume that scattering didn't change over time. Or you could see delta changes in hemoglobin concentrations. You can also measure oxygen saturation. STO2. This is tissue oxygen saturation. It's the amount of oxyhemoglobin over total hemoglobin. So continuous wave techniques, and I'll talk about one later in the talk, they're very useful for looking at changes that happen over short timescales. So for example, measuring the cerebral activation in the brain uses continuous wave. We call that technique NIRS. But our lab for breast imaging, at least in part, focuses on frequency domain diffuse optics. So here we intensity modulate the light, and we look at both the reduction in amplitude and the shift in phase of the so-called photon density wave that travels through tissue. So time domain is related. We can send a pulse of light and look to see how the tissue transforms that pulse into a temporal point spread function. Both of these techniques give you enough information to separate absorption from scattering and quantify it at each wavelength you probe the tissue. And this allows you to extract molar concentrations in the tissue volume. So absolute values of oxy and deoxyhemoglobin, or if you're in muscle, myoglobin, water, and lipids. And so this is useful for longitudinal studies that occur over weeks or months, like we do in breast cancer, where we're trying to see if a patient changes over long periods of time rather than short periods of time. So how does frequency domain dose work? Well, we start with a bank of laser diodes. Here's an example of a set of laser diodes we use. And we intensity modulate them, as I mentioned, and we look at the frequency response of the tissue, the optical frequency response. So we build up this Bode plot of sorts, where you can see a decay with frequency, and we're using frequencies in the megahertz, and an increase in phase shift at longer or at higher frequencies. We can fit this data to a so-called inverse model, and we use versions of the diffusion equation, an approximation of the radiative transport equation, to allow us to extract the absorption coefficient, which I talked to you about before, as well as the reduced scattering coefficient. And I'm just showing the absorption coefficient here for the moment. So we can get a mu A at each wavelength of illumination. And then we have prior information, right? I showed you this spectra of oxy, deoxy, water, and lipid. We can look at the extinction spectra, which people have measured, and it's in the literature. And we can add these in a unique way after making assumptions about homogeneity of the tissue to reconstruct a total absorption curve. And using what's called Beer's law, this is how we get concentrations of oxy and deoxyhemoglobin. Now we get concentrations of water and lipid, we tend to put them in units of percent of pure water, but we could just as easily put them in molar concentrations. What does the instrumentation look like? Well, the instrumentation is still being developed. There's one commercial device available, but not for clinical usage, only for research laboratories. So we make our own frequency domain diffuse optical spectroscopy devices. And these days we're using all digital electronics, and we make them completely custom. So it starts with hardware. We use fast digital hardware. And I'll go through this very quickly, but we use direct digital synthesizers. These just generate high frequency RF electrical signals that we use to drive our bank of laser diodes. We modulate them all simultaneously and illuminate a sample. We collect with an avalanche photodiode. This is a highly sensitive photodetector. And we send the collected light into one channel of a very fast analog to digital converter, which we compare to a reference. And this is how we get the amplitude and phase. We have to do a calibration technique to get rid of the instrument response. But after that, we can get the amplitude and phase shifts induced by the sample itself. So after the hardware, there's firmware where we can do demultiplexing operations, and we can do fast Fourier transforms or other mathematical operations to get our amplitude and phase. And then we have an inverse model. We can either use an analytical solution. More recently, we've been using deep neural networks to do very fast optical property inversions. So with our latest hardware, we can get real time up to 27 hertz, 6 wavelength optical property extractions. And then from these optical properties, the mu A and mu S prime, we can also calculate the tissue chromophore concentrations. And we take
Darren, may I ask you a question?
Absolutely.
Okay, this is Guido Giuliani from the University of Pavia. In this frequency domain DOS system, are you considering a transmission setup or a reflection setup? I mean, what is how do you go through the sample? I mean, it's where do the illuminator, fiber combiner, and APD stand with respect to the sample? Same side, or you go through the sample?
Yes, thank you. So we've done both. And you can see our source detector and fiber here on a finger. This is reflectance geometry. And in the breast, we do reflectance geometry. So the source and detector fiber for breast measurements tends to be 28 millimeters of source detector separation in reflectance mode. Now,
okay, thank you so much.
Yeah, no problem. And that's the data I'll be showing you, but just for context, other groups use even transmission through the breast in some cases. But we're reflectance for this. So we take our handheld probe and an operator literally moves it point by point, taking these measurements in a centimeter by centimeter grid. And each point measurement, we can then just simply interpolate to get a topographic map. And this is the same map I showed you before. And what we're looking at is a map of deoxyhemoglobin times water divided by lipid. We call this the tissue optical index. It's just simply an empirical index that in the past we've seen gives us high contrast for tumor. But we can make maps like this for the other chromophores as well as absorption and scattering. This is what we track through time. So you can imagine if we image a patient today and then 2 weeks from now, we can look at this region of interest and see if anything's changed. So in the clinic, what we do is we measure patients that are undergoing chemotherapy, a specific type of chemotherapy called neoadjuvant chemotherapy. Neoadjuvant simply means before surgery. So same MRI image that I've showed you before, just to get a sense. We start with a tumor like this, and we hope to end like this, where that tumor is gone. And this occurs over a period of multiple weeks and months, often 12 weeks, but it depends on the specific regimen and hospital. And the data I'll show you today, the clinical data, is all from the first week after the very first chemotherapy infusion. And we target that first week because this would be really nice for clinicians to be able to tell if this patient's responding or not early during therapy. Our group and others have also looked later during the neoadjuvant chemotherapy timeline, but I'll just show you the week 1 results today. So we just published in 2020 a relatively large study, multi-site study from UC Irvine and Boston University, 53 subjects and 54 tumors. The average tumor size was 3.5 centimeters. And we took dose measurements at baseline, so before the very first chemotherapy infusion, and then at least 3 times during the first week. And the breakdown occurred like this, and it'll just take me a second to explain this, but we had 53 subjects, 54 tumors. These patients were not all treated the same way. 35 were treated with what we call maximum tolerable dose, or MTD. And I'll explain exactly what that means on the next slide, but it's the standard of care chemotherapy. And of those subjects, we had a response rate of 69%, meaning that 11 of the tumors we measured didn't respond to treatment by our criteria, but 24 did. Now, there was an experimental drug trial going on while we were doing our imaging study, testing a new type of chemotherapy called metronomic. And here we had a lower response rate. But this gave us a really interesting opportunity to explore how DOS could monitor 2 different types of chemotherapy to see if there was any differences. And I'll just note that age and tumor size were not significantly different between these groups, giving us more confidence that we could compare them. So MTD, or maximum tolerable dose, is chemotherapy given every 2 to 3 weeks. And this diagram to the left shows you the theory behind it. So you give a large dose, you reduce the tumor burden. This could be a surrogate for tumor volume rapidly, but you have to give time for the patient to recover because this treatment is quite toxic. During that recovery time for the patient, the tumor may also recover and regrow, but you repeat this to the point where you try to eliminate the tumor. Metronomic gives a smaller dose more frequently, and the idea is that this gives you potentially fewer side effects, and it's been noticed that it has a more anti-angiogenic effect. This means that it's more blood vessels are more sensitive to this type of dosing, even when given the same type of treatment, the same drugs. And that's because, we think that's because you're bathing these endothelial cells in chemotherapy without giving them breaks, and they're differentially sensitive to, say, tumor cells or other cell types. So these are the two types of treatment we were comparing. And of course, there's a lot of data from a study like this, but I'll show you the end result here, the most interesting result. So separating between maximum tolerable dose and metronomic on the left and right, you're seeing days post chemotherapy. So here's baseline and then the first 7 days, and then repeated here. And then the y-axis is the change in tumor oxyhemoglobin. And what you can see is in the responders, we have this flare. We call this an oxyhemoglobin flare that occurs on the first day after the first infusion and dissipates to a large degree by the end of the first week. We don't see that in the non-responders. So this is, really exciting. This separated quite well the responders from the non-responders in the MTD group very early during treatment, but nothing here in the metronomics. So in the metronomic setting, none of the hemodynamic parameters allowed us to separate responders from non-responders. Number of reasons could be for that. I mean, lower dosing here is high on the list. Actually, different drugs. So a few different confounding factors, but here, separate non-responders. And a number of different, including longitudinal regressions, but also discriminant analysis. And I'll just show you the linear discriminant analysis results. For the maximum tolerated dose, we can get a very high area under the curve on the receiver operating characteristic curve. So the larger area under the curve going this way, the better our ability to discriminate responders from non-responders. And the metronomic, an AUC of 0.5 means that it's tossing a coin. You really have no predictive ability. And here are the sensitivities and specificities, as well as the positive and negative predictive values. So what's happening on that day one for the MTDs? Why do we see this oxyhemoglobin flare? Well, all we have is hypotheses at this point, because we don't have enough information to know definitively. One hypothesis we have is that this is an immune response, that once that tumor receives that bolus of chemotherapy, we're damaging the tumor cells. This is causing immune cells like macrophages to release vasodilators that expand the capillary bed, increase permeability. Our second hypothesis is that there's a rapid metabolic drop or metabolic catastrophe. So if we're damaging those tumor cells quickly enough, their demand for oxygen should go down, and then they'll just simply be a buildup of oxyhemoglobin that's not being utilized. So either could be the case. In order to determine really what's going on here, we need to do a few things. We can measure blood flow. And if we measure blood flow and hemoglobin concentration simultaneously, that allows us to get our level of metabolic oxygen utilization or consumption. And that could tell us about the difference between an immune or a metabolic drop. But we need a second technology called diffuse correlation spectroscopy that measures blood flow. We could also measure immune markers. We could do this in humans using blood or biopsies, which are difficult in humans. We're also trying this in small animals to see if we can recapitulate and get a better sense of this biological phenomenon. But the big picture, again, the bright point here is that DOS is sensitive to treatment response at, in this case, a very early time point, but for a specific regimen. And fortunately, it's for the standard of care regimen, but we recognize going forward that dose imaging markers are likely regimen specific and biological mechanism specific. So we can say that dose may be useful for personalizing cancer therapy in the future for breast cancer patients. And that's where we are with that project at the moment. And I'm going to switch gears now to the second chapter, where I'm going to talk about diffuse optical technologies during COVID and beyond, but still, we're going to come back to breast imaging again. So to start this second part of the talk, I just want to discuss a few definitions here. So wearable technologies, most of us are familiar with that. A Fitbit could be a wearable, but there's also FDA approved or healthcare system approved technologies. These are physiological monitors that move with us through our day. typically attached, tethered to a phone through Bluetooth or physically, and data can be uploaded to a cloud. Other home monitors, think blood pressure monitor, pulse oximeter, can also be connected through the cloud or through telecommunications. And telehealth is allowing us to communicate with doctors, physicians, healthcare providers through Zoom or other means. And all this comes under the setting of remote patient monitoring. So this is healthcare delivery outside of the traditional healthcare setting. So combining devices and telecommunications. And really there's been a big move towards this during the COVID-19 pandemic, but I'll make the case even before the COVID-19 pandemic. To give you a little flavor, some personal data here. This is my Fitbit data during COVID-19. So I typically walk a lot when I'm working normally. I take the train for a few stops and then I walk, both to and from work. So before the pandemic, I was averaging, above about 13,000 steps a day, which is generally considered pretty good. And as soon as the Massachusetts stay-at-home order hit, me and my wife, as well as everybody else in the world, basically stayed at home. And we really stayed at home a lot just to take the dog out, is when we went outside the house. And then as we started to reopen during late of last year, we went for longer walks, but mostly working from home. And this deficit period here is quite dramatic. During that time, I had 6,000 fewer steps each day. I covered 2.4 fewer miles and burned approximately 400 fewer calories. And so this has, deleterious effects likely on heart health, but certainly on waistline. That's some direct evidence that, I'm very aware of. But this is just an example of, even with a healthcare system where it's difficult to go see a doctor, we can still keep track of our health to some degree because we now have these monitors that move with us. And remote patient monitoring was on the rise prior to COVID. So many of the healthcare providers in the US were already investing in different remote patient monitoring or RPM technologies. We've seen the rise of these huge wearable studies. So Fitbit measured 18,000 patients, not patients, 18,000 participants in a study looking at mortality risk. And then there's the Apple Watch study of over 400,000 Apple Watch wearers looking at atrial fibrillation. And these studies really are quite different than a lot of other clinical studies. They take a pragmatic approach where people go about their day as they normally would. In the case of the Apple Watch study, there was no in-person contact with study subjects or physicians, even to validate that the watch could detect atrial fibrillation. What the study did is they mailed out an ECG patch that a patient would put on to try to confirm the diagnosis of atrial fibrillation. So really a new way of conducting a study. And then in the US, this is very particular to the US, but there's been new CPT codes. So these are healthcare codes used by the federal part of our healthcare system that allow reimbursement. And these new codes allow a physician to get reimbursed, say, for helping a patient set up a pulse oximeter at home and then getting that data from the patient and then making clinical decisions based on it. So this is kind of a new thing for physicians to be reimbursed for remote patient monitoring. And then during the pandemic, of course, telehealth was up 26,000% in the Northeast of the United States where I live, to the point where it occupied 20% of all healthcare claims in April 2020. And this has remained high, not this high, but it's remained high through the rest of the pandemic. There's been moves to make equivalent reimbursements. So whether you see a doctor through Zoom or whether you see it in person, those reimbursements are the same. Our Federal Drug Administration has relaxed some enforcement on devices like the ones you've seen here to make it easier for people to use these devices at home. So even if they've been marketed in hospitals, you can now use them from home, at least during the pandemic. But the secondary health effects of COVID-19, are going to be with us for quite a while. So there's fewer doctor's visits, delayed diagnosis, delayed treatment, less screening, reduced and non-standard care. And the National Cancer Institutes here in the US has done some modeling. This was last summer. They did this modeling, trying to estimate how many excess deaths there would be from breast and colorectal cancer due to these secondary health effects. And this is a plot over the next decade showing that we'll have excess deaths more than we would have otherwise without the pandemic. About 10,000 excess deaths from these two cancers over the next decade. You see it peaks and then it trails off. And I'll just emphasize that this analysis was done months ago. So this may very well be exacerbated at the point we are now. So what role can diffuse optics, optical technologies, and wearables more generally play during the COVID-19 pandemic and beyond? Well, there's COVID-19 itself, and there's been some really exciting new papers on using smartwatch data to detect the early signs of COVID. And I refer to a Nature BME paper down here that was published not long ago, and there was also a New England Journal of Medicine paper. And they're getting a lot of press, which is exciting. And along these secondary health effects, there's lots of opportunities here. So screening, can we screen patients at home for different diseases? Treatment monitoring, patients still need to have surgery during the pandemic, but can they do the recovery at home? Wound healing is huge, need lots of care. Clinical trial monitoring and neural monitoring are just some. We have a number of projects in this area, including a wearable hydration edema monitor that we're looking at for kidney failure, non-invasive measurements of blood lipids, respiratory monitoring during mechanical ventilation. But I'm going to focus again on breast cancer imaging to maintain continuity with the first part of the talk. So the status quo, whether it's the handheld probe I showed you earlier, the frequency domain diffuse optical spectroscopy, or a tomography system, this is one that another group made. And so the breast goes in here and you have many optical fibers coming to and from the breast. This looks a little scary to me, if I can be honest, but you know, these were exciting and are exciting technologies that give us a lot of information, but they lack portability, right? You really can't ask a patient to take this home with them. It probably doesn't make sense. So we've been working on a wearable version of this technology for the last few years that's more flexible, both in terms of where you can measure, but also physically flexible. And we've been testing this to see if we can get information that may help us, again, track treatment response in breast cancer patients. Here's just a few pictures and a specification table giving you a few details about this. So this is a custom made, we call it a flex rigid printed circuit board design. So we have these rigid panels. You're looking at the top and bottom of the circuit here, and they're connected with flexible printed circuit boards. So this is similar to the flexible circuit board that might be between your keyboard and your screen on your laptop. And there's an array of LEDs and photodiodes here. Actually, yeah, I have one I keep. If you can see that, this can bend quite nicely and conform to tissue. And we encase this in medical grade silicone. We adhere it to the breast using tegaderm tape. This is just IV tape. 2 wavelengths of light, 750 and 850 nanometers. So that gives us sensitivity to oxy and deoxyhemoglobin. So not water and lipid in this case. And we can take many different measurements from each source and detector. That allows us to do both topography and tomography, and it also allows us to segment our data into different depth sensitivities. And I'll show you this slide again, but the wearable technique is continuous wave. Remember I told you about continuous wave? It's really useful. Changes in absorption or hemoglobin content, shorter periods of time. So a question for us is, you know, what hemodynamic changes can we look at in the breast that might still tell us about tumor physiology and response when we don't have the ability to get these molar concentrations of hemoglobin like we did before. So what we're looking at is dynamics. And the way I want to tell you just a little bit about how we tested the probe in the lab before we started measuring subjects. But here's one of our setups. This is a probe. We make it in different colors, but we're putting. So this is a silicone phantom that has titanium dioxide and nigrosin to match the optical properties of breast tissue. And it has two channels, but we're only using one of the here that's below the surface of the phantom. And so we can use a syringe pump to pump liquid containing nigrosin, intralipid, and water. And so we have intralipid followed by a higher density of intralipid with nigrosin. So as we push this, in this channel, we're going to go from less absorbing to more absorbing underneath this part of the phantom. And here's our X and Y dimensions. So now we're looking down at the top of the phantom, and we can do topography. And these are videos. Oops, let me start that again. Here we go. So the channel is here. The channel is here. You're looking at the reconstructed data topographically, and the change in mu A at the two different wavelengths, 750 and 850 meters. And you can see that contrast change. The two different columns are two different source detector separations. So here we're looking at an interpolated map of all the 22 millimeter source detector separations, and here are all the 30 millimeter source detector separations. So we have a little bit deeper sensitivity with the 30 millimeter. And you can see that because we can put channels at different depths and test the different sensitivities. So this is one way we validate the technology. We can also take the same data set and do tomographic reconstructions. We use the right-top approximation. And now we're looking at Y versus Z instead of X and Y. So the side view of this channel. And here's the reconstruction here. We do a pretty good job, except that we reconstruct more shallow. And this is a common problem. Tomography with diffuse optics is an ill-posed problem. So limited information. And one of the common issues is you tend to reconstruct a little bit shallow. Testing in vivo, before we measured the breast, very common way to measure diffuse optical technologies to do what we call a cuff occlusion test. So similar to getting your blood pressure taken, cuff on the upper arm, and we inflate that to the point where we're going to collapse both veins and our arteries. So relatively high pressure, and then we're going to measure the hemodynamics of the lower arm. Here's an example. We're looking at a plot of deoxyhemoglobin shown in black and oxyhemoglobin shown in red. And the solid line is the average from all the 22 millimeter optoids on the probe. And then the shaded region is the standard deviation of all the different measurements. But you can clearly see a pattern here where oxyhemoglobin is decreasing and converting to deoxyhemoglobin. So with no new blood supply, no new oxygen, no drainage. So the metabolism of this arm is just consuming oxygen, and that's what you're looking at. And as we look at the longer source detector separations, you can see that this goes away to some degree in 41 millimeters, not 50 millimeters. And we're looking deeper as we go from shorter to longer source detector separations. We can do modeling. So depending on the tissue optical properties, we're imaging about twice as deep, or at least getting photons from, on average, twice as deep from this source detector separation compared to this one. It's actually not totally clear to us why the vascular occlusion response here is diminishing with longer source detector separations. But what about on the breast? So again, we need some dynamic contrast is what we're looking for. And it wasn't totally obvious what dynamic contrast is available in the breast. And we spent several months trying different contrasts. And what we've settled on currently is paced breathing hemodynamics. So what does that mean? We put the probe on the breast. So far, it's just healthy volunteers. And we ask the subject to slow down their breathing. So inhale for 5 seconds, hold for 10 seconds, exhale for 5 seconds. So this is similar to yoga breathing. You slow down your breathing, and what happens? When we measure with the wearable probe and we filter at the paced breathing frequency, we can see oscillations at the paced breathing frequency in oxy and deoxyhemoglobin. So the paced breathing, when we ask the subject to breathe at the slower rate, is between the dashed lines, vertical lines. So much less signal before. Why is this occurring? Well, when you breathe in, your diaphragm moves down, your chest moves up, and in your intrathoracic cavity here, the pressure goes down. Pressure in the thoracic cavity goes down, and pressure in the abdominal cavity goes up and the periphery. That means that blood is moving from the periphery to the heart in the thoracic cavity. And this primarily affects the venous circulation. which is very compliant and has a reservoir of blood. And then when you breathe out, the exact opposite happens. And this is called the respiratory pump, and it's well known to affect venous return. And this is what we believe we're seeing here. What's really interesting about that is if we can measure just signal from venous blood, this allows us to get something called venous oxygen saturation. And it's the flip of the coin from what a pulse oximeter measures, the arterial oxygen saturation. So pulse oximeter measures the change in blood absorption due to a change in blood volume with each beat of the heart. But that changes the volume of the arterioles and arteries. This is changing the volume of the veins and venules. So one gives you arterial oxygen saturation, the other gives you venous. And the difference between the two is how much oxygen tissue is extracting. And I'll just note that this breathing signal is quite a bit lower than the cardiac signal by several times. So there's some major SNR issues we've had to overcome to get these signals. I'll also notice that, make note that as we slow down breathing, the amplitude of these oscillations tends to increase, which is quite interesting, and it's something we're currently studying. So we can take these waveforms and calculate the delta oxy and deoxy and get what we're calling a respiratory saturation, change in oxy over change in oxy plus change in deoxy. And this is a surrogate, we think, for venous oxygen saturation. We call it R for respiratory because we haven't yet confirmed this. So we'll call it respiratory oxygen saturation. Just like in a pulse oximeter, they call that typically SpO2. It's peripheral oxygen saturation, which is a surrogate for arterial oxygen saturation. But as I mentioned, fractional O2 extraction, or how much oxygen tissue is removing from the blood, is the difference between arterial and venous. And if we have a surrogate for venous, we know arterial for healthy subjects, even if you have cancer, it tends to be pretty constant. So we've started to measure SRO2 as a potential new metric to look at breast dynamics. And we can see at different source detector separations, there's actually a decay in SRO2. We can see this is a zoom inset without the longer bars here showing the outliers and the quartiles. But you can see there's a drop in SRO2 as we go deeper. So again, this depth dependence, which is quite interesting. And because tumor vascular structure is so different than normal, and because we know the metabolic activity of breast tumors is so different than the surrounding normal tissue, which you can see through FDG PET, we're hypothesizing that this SRO2 metric may provide a new source of tumor contrast with this wearable probe, which we then can use to measure patients longitudinally as they're getting chemotherapy. And this remains a hypothesis. I mean, we were really unfortunately set up to go into the clinic to measure our first breast cancer patients before the pandemic. And we just got approval to start that again. So actually in the next few weeks here, we hope to get our first evidence that could point us in either direction about whether SRO2 is a useful parameter going forward or not. So to conclude, in the first part of the talk, hopefully I communicated that diffuse optical techniques have the potential to identify early treatment-specific responses in breast cancer. And that newer optical wearable diffuse optical technologies hopefully have an increasingly large role to play during this changing healthcare landscape. And if we can make devices portable that can move with the patient, we have opportunities for tracking treatment, not only in the clinic, but also wherever the patient happens to be, including at their home. And then increasingly remote world, at least for now, which is sad, this could still be quite useful to many patients, we're hoping. So I'd just like to acknowledge my lab, the students who really worked on these projects. So Faye made our first version of the wearable probe, and Sam Spink is now doing the measurements on healthy volunteers and is going to go into the clinic. For the first part of the talk, Anoop Tank, who you see in the back, did a lot of the analysis and statistical analysis, the diffuse optical technology, and then Sieta Tabassum and Hannah Peterson, who are now both doing postdocs at great universities, did a lot of the work in measuring the subjects and getting a sense of what the data was telling us. So I'll stop it there, and I'll stop sharing my screen, and I'd be happy to field any questions that anyone has. And I thank you for your attention. So I see a hand up, but how would you like to handle questions, Valentina?
Okay, yes. Yeah, let's thank Professor Roblyer for the super interesting seminar. And please, if you have questions, feel free to ask.
So can I?
Yes,
Yeah,
please.
yes.
Hi, thanks for your great lecture. And I'm Ali from University of Genova. I was wondering about using SPAD array in wearable tools so that we can have, when we are using impulse response or very short pulse durations, we can have both temporal and, let's say, coordinate information also from, let's say, very localized SPAD array in different regions of the wearable device.
So did you say a SPAD?
Yes.
Yes. So actually, you know, in your country, in Italy, some of the very leading edge work in SPADs and time domain diffuse optical spectroscopy is taking place. And it's really fascinating. You can do a lot of fun things with time domain diffuse optics. You can look at early arriving photons and late arriving photons that help you, again, differentiate superficial tissue from deeper tissue. And there has been some work in trying to make portable or wearable versions of time domain systems that utilize SPADs. And let me know if I'm misinterpreting your question. But the time domain technology is just much more sophisticated. It tends to be a lot more difficult to make miniaturized. Same with frequency domain, which is why our wearable probe uses CW, simple LEDs and photodiodes. Does that get to the core of your question? I'm a little worried that maybe I misinterpreted.
Thank you so much. Yeah, I got it.
Okay.
Okay, other questions?
Yes, I have a question. Hi, I'm Martina. I'm from the University of Pavia. It's just a curiosity, actually. I want to know what is the resolution of this imaging system? I mean, like the smallest tumor in breast that you can detect.
Yeah, that's a great question. Thank you. So, you know, resolution is tricky with diffuse optics because it depends on many factors. It depends on the optical properties of what you're measuring, right? If you have more scattering, then your resolution is going to go down. It also depends on the geometry of your probe, so how close the source and detector are. It also depends on how you scan the tissue. We've done recent work that shows if you take a lot of measurements close to each other, you can improve spatial resolution. It also depends on the modulation frequency. So that segments your measurement in depth to some degree. So that's a number of caveats, but to give you a rough estimate, our spatial resolution tends to be on the order of several millimeters. So in the case of breast cancer imaging, what we know we can't do is use diffuse optics effectively to find a small tumor. So we don't think it's a replacement for mammography. It's just not going to be good at measuring new tiny tumors. What we use it is for measuring these locally advanced tumors that typically are already several centimeters. So the smallest we've imaged is a tumor that's maybe a centimeter in diameter. And for tumors like that, we typically have no trouble seeing contrast. For smaller than that, it would be probably pretty tough.
Okay. Okay, so thank you.
Mm-hmm.
Thank you also for the great seminar.
Thank you very much.
Other questions?
Here. Hello, can you hear me?
Yes.
Okay, hello. David Marzi here from University of Pavia. Well, first of all, thank you again for this super interesting lecture. So mine is just very simple curiosity. When do you think this technology will be stably employed in hospitals?
Yeah, not a simple question at all, but such an important one. So As I mentioned, there's one commercial technology that uses frequency domain diffuse optics. And it's been around for a long time. It's been around for more than 15 years. And they've decided to stay in the research domain. They have decided not to go after FDA approval. They tried early on, I know a little bit of the history of this company, and then decided to stay in research. So the question is, what stage is this technology in terms of finding the right clinical application that's going to make the first breakthrough into the clinical space? And I'm quite hopeful that breast cancer imaging will be among it, but it's certainly not the only application that our group and others are using. I mean, we're looking at muscle physiology for a number of different applications. The sports field is much easier to get into, right? Because there's less approvals, at least in the United States. So it takes some enterprising group or individual to really push this towards commercialization. And it has to make sense in so many dimensions in terms of regulatory approval and commercialization. So I feel like with the last few questions, I've been giving very long-winded and very caveated answers. But the technology is in such a place that if we wanted to make a device and mass produce it, those are engineering technical challenges that can be overcome. It's really the rest of the fit, the regulatory, the right application, and is there a market big enough, and can you get funding for it that has to work? Now, after saying all that, I will say that there's a related technology I didn't have time to talk about today, a diffuse optical technology called spatial frequency domain imaging. It has same principles. Instead of modulating light in time, you actually modulate it in space. So you project a pattern of light onto tissue. That technology came out of the Beckman Laser Institute where I did my postdoc. That's currently being commercialized. It has FDA approval for looking at diabetic foot ulcers. So trying to determine whether those foot ulcers are going to be a problem or not early. And so that is the best we have for a success story in diffuse optics so far in terms of commercialization, and it's there. So I think that's how I'd answer that question.
Yeah, very clear. Thank you very much.
Actually, I have a curiosity myself. So are you thinking about moving towards other application, for example, also to the animal side? I mean, I know that there are some technology because I also worked on transillumination, near infrared transillumination in the past. So I know that there are some applications also, for example, related to egg counting or chicken embryos controlling. So I think that that field would be easy to push towards, because maybe there are some less bureaucracy and less rules to follow. So I don't know if you are thinking about also other completely different application.
Yeah, I love that idea, and you're right. Thinking about the path of least resistance can be useful for commercialization. But I will say, with our clinical data, there's so much about the clinical data in the breast cancer patients that's, we have hypotheses for, but we don't know exactly why we're seeing what we're seeing in all cases. And so there's several other projects in my lab where we image small animal tumor models, where we can, resect the tumors and look at molecular immunochemistry and things like that. And I didn't have time to talk about that today, but there's a suite of diffuse optical technologies that are suitable for those types of applications. And then we also do intravital microscopy with multiphoton imaging to, again, give us more information. So related to the tumor imaging, we do both animals and humans. In terms of humans, cancer is certainly an important application, but we're starting to look more into cardiovascular applications. There's actually a large open space here where there's not been a lot of new technologies. There's a lot of money pumped towards cancer, a little bit less towards cardiovascular. So I see that as an opportunity space. And then taking that further completely outside the domain of maybe human health, I think is a great idea and something that probably I don't think about enough. There's been some early or some others have done work for using that spatial frequency domain imaging technology, this imaging technology, this diffuse optical technology, for looking at apples to try to determine whether they're ripe or not.
And also the other people, other groups were looking at onions also.
Yeah,
I
right.
read in the literature. So, and also, have you think about, for example, skin cancer? That could be also another field.
Yeah, exactly. So diffuse optics is in some ways well matched to skin. And so I guess I'll say there are people working in this area with similar techniques.
Okay.
But to zoom out a little bit, you know, let me be careful with what I'm saying here, but the skin is so accessible that there are many, many groups using many different technologies trying to look at skin. So not in terms of the biological interest, it's well suited, but more in terms of the research landscape, it's a more crowded area. Does that make sense?
I see. And I have just one final curiosity. Have you, I was wondering if you have seen that your system imaging works well with women that have breasts with a smaller dimension or not?
Yes.
So more or less.
That's right. So by now we've used the handheld probe. So when I say we, I mean me and then the group I came from where I did my postdoc, and then we had a consortium of multiple groups around the country. But we together have imaged hundreds of breast cancer patients with the technology. And I will say one of the challenges with smaller breasts is the chest wall. So if you can actually image through the breast tissue, the muscle of the chest wall is quite absorbing and can mask the tumor to some degree. And that tends to be the biggest issue for women with smaller breasts.
Okay, thank you so much.
Yeah.
Okay, so if there are not other questions, I think that we can thank again for the last time Professor Roblyer for your seminar. It was really a pleasure for me to host you, also because we had the pleasure to meet face to face. And so I hope that we can hear soon from you and from other seminars or webinars. So thank you so much.
Agreed. Thank you so much for the invitation. Questions were great. Thank you for the audience for being here, and would love to see you, Valentina, and everyone else in person, hopefully sometime soon. So yes. Best of health and thank you all.
Also to you, and good luck with your work. That is super interesting.
Thank you.
Okay, I will stop the